as just a continuum, a realistic continuum in today's world?
I do. I think PrEP is a great idea. I can tell you this in my own practice, where I see 60, 80 people a week, I've offered PrEP to one person. Now, part of it is most of the people I take care of are already positive, but they often come in with their partner, and it's pretty hard to, there's not a lot of PrEP being given out in my world, but again, I have just my own view. But let me not digress too long from this, but these are real questions, and I don't have the answers for them. Let me just talk a little bit about, because I've got to stay on schedule. I have until what time, just so, Heshi? Till 1:45 or so? Or now, 10:30?
Till 10:35, 10:30.
So I have 10 minutes. Let's just talk a little bit about health issues. And epidemiology we can talk later about. I just thought I would run through sort of organ-based disease for older patients with HIV. Number one, starting with the brain, about 5% of all patients with HIV will get some premature loss of cognitive function, a little early dementia. It does not seem to get worse with age. It tends to happen relatively early, often in the disease. Medications certainly improve it and slow it down, but they do not eradicate it. From a patient's point of view, is there anything one can do? Just take your meds. Take your meds, do the crossword, use your brain, stay active intellectually. That's about it. Don't go play football for the NFL and get bumped on the head. Number two, let's talk about heart disease. Heart disease is a real issue. Having HIV, even if well controlled with a zero viral load, you are still at risk. You are at higher risk for developing coronary artery disease like a smoker, like somebody with high cholesterol, high blood pressure, and obviously plenty of people have those issues also. In our practice, all of our patients that are on HIV, who are HIV positive on meds, should be on cholesterol drugs, should be taking a baby aspirin each day, should have their blood pressure controlled, and if you're smoking, do everything we can to get you to stop smoking. But are you at much higher risk for coronary disease? Yes. Why people are living just as long with HIV as those without is that modern cardiology technology is so good that people are now not dying of coronary disease. You get stented, you get bypassed, and so on, and you survive. But it's just yet another problem. Number three, lungs. I would say 25% of our HIV positive patients smoke. And there is a well-documented increased risk of cancer, particularly lung cancer, in HIV positive people, folks that smoke. If you can stop smoking, go for it. Is emphysema worse in HIV positive people? Yes, it also is. Why? HIV is an inflammatory disorder. It probably provokes emphysematous changes in the lung. Why give $10 a day away to that idiot Mr. Corbett and the manufacturers of cigarettes when you can't, when you don't have to? Don't. Put the money in a coffee can, take yourself on vacation, stop smoking. Let's talk about kidneys. Unfortunately, there are a variety of kidney issues that are associated with HIV. Number one, what we call HIV nephropathy, which is really poorly understood, but patients slowly develop kidney problems out of the blue from HIV. If you're African American, at much higher incidence. Number two, the drug tenofovir, which is combined in Truvada, which is combined in just about everything now, is by and large a safe drug, but will certainly predispose you to kidney issues. Most of us in this room are at least 50, getting older, many of us over 60. And I don't know about you, but I'm taking more and more ibuprofen and naproxen. And it's my friend. And it's not good for your kidneys. So if you throw in HIV, a little Advil, a little bit of tenofovir, and you happen to be African American, you've got a good prescription for having some kidney issues. Let's talk about genitals. Low T, absolutely a problem as you get older. All men lose their libido to some extent. The testosterone levels will fall. If you're HIV positive, it tends to be a little more accelerated. I think for my wife, she's thrilled and delighted that that's happened. But not everybody feels that way, and it's an issue. The problem is that if you supplement older people with testosterone, you will actually promote coronary artery disease. So these midline organs are really at risk. And the answer to that situation is not clear. What else? I think those are sort of the major issues from a health perspective. Blood pressure, I don't think blood pressure is particularly related to HIV. I think it's over the age of 50, about half of people are hypertensive. The biggest issue with hypertension is being overweight. If you lose weight, your blood pressure remains normal. It's totally weight driven. If you're African American, it's a little you're at more at risk for worse blood pressure at an earlier age. But if you can get to your lean body weight, which is a challenge, you can get rid of your blood pressure problems. How do you lose weight? It's become very clear. If you don't eat carbohydrates, you won't get fat. If you don't eat carbohydrates, you won't get fat. And that includes beer. All right, so I think, oh, I forgot liver. Let me just do liver and then I'll do hands. Liver. Hep C, 3 million people in this country with Hep C. About 20% of them will go on to develop liver failure and be potential candidates for transplantation. We now have some superb drugs for hepatitis C. Unfortunately, the price of these drugs is beyond belief, $125,000 for a 3-month course of therapy, brought to you by our friends Gilead, who are charging an absolutely immoral amount of money for these drugs, I believe. But they're effective. They're very effective. Many insurances are paying for them. HIV drives Hep C. Hep C drives HIV. The current state of the art is treat the HIV first, then get people into care for their Hep C. Hep B is much less of a problem, but clearly out there. The good news about hepatitis B is that Truvada, M-tricytidine, and tenofovir are highly active against hepatitis B, and often you get 2 for the price of 1. You get Hep B coverage, and your HIV is covered. So not such an issue. The third part of liver disease is fatty liver, and that's from being overweight. It's from the lipodystrophy associated with HIV and HIV meds, and it's actually the number 3 cause of liver disease in our HIV population. NASH, which is it's basically non-alcoholic steatosis. It's basically being heavy. Fat deposits in the liver and ruins it slowly. So be thin, eat well, cut out your carbohydrates, take your meds, tell your friends to take your meds. I take my meds. They take their meds, you take your meds. And let me stop there. Yes, sir.
Question. Being HIV positive, it is true not, is it not, that if your T cell count is 150 or 200, you're in a different situation than being HIV positive if your T cell count went from 200 to 700. If you have a 700 count and it stays 700, do you still have all of these chances of getting all these horrible diseases more than an HIV negative person would?
All right, let me answer that. It's actually a great question. If you are in care and your viral load is undetectable, whether your T cells are 150 or 700, you will not develop an HIV-related opportunistic infection. Okay?
The liver, the kidneys, all these other things.
Hold on. All these diseases that I just mentioned, you are still at risk for independent of your T cell count. Independent. I'm not talking about opportunistic infections, PCP and Cryptococcus and Kaposi's. Those diseases, to a great extent, have left the station. I don't see much of them anymore. I'm seeing this sort of stuff. I am actually now back to being a primary care